Women in your 30s and beyond, are you tired of being told how to feel? Like all of the products are forced on you? Doesn't it feel like these big companies categorize you when the truth is they don't know you? Listen up. I'm Dr. Jila, an OBGYN and women's health expert. This is my podcast, Her Time, Her Health with Dr. Jila. Welcome to the show, Dr. Robyn Roth. I am so excited to have you here today.
Thank you so much. I'm so happy to be here. I feel like this has been a long time coming.
Oh, I can't say enough about you. I've been following you for a while now, and you know, so much of what you say resonates, and it's like what I'm saying on this end, and I'm like, wow, you know, we need this kind of information for women because I see this all day long, breast imaging. Why do I have to do a mammogram? So much going on out there.
Yeah.
And I want to get into all of it with you. I have so many questions that I want you to kind of explain for our audience, because women have questions, they get confused. There's a lot of information on social media, some good, some not so great.
Yes.
And so I need experts such as yourself in the field of what you do, which is, you know, you are a breast radiologist. You're looking at women's breast tissue all day long. So you're the one to go to.
I'm the guy, right?
You're the guy, exactly, for all of this.
Yeah, it's so important. And that's why I decided to get online, because I was really fed up with the misinformation that women were getting. And men, right? Men get breast cancer too, and men have breast imaging as well. So I just feel like, you know, social media is so powerful for both good and bad. And I eventually, as a breast radiologist, I got fed up enough that I decided to get online. And I'm so happy I did, because it's really, you know, I realize the amount of people I'm able to help with this silly little video. It's so impactful, and we need more voices that are evidence-based and providing factual information, not trying to sell you something alternatively. And I think that's the key point here.
Very much so, because there's, you know, women are scared. I think they're not sure what to do, who to listen to. Yeah. They don't know when to start imaging. And when they do, you know, the worst thing you want to hear is, okay, I know we need you to come back for another view. We need an ultrasound. We may need a biopsy. Yeah. And all of these things are, you know, shocking to a woman. Yeah. Some women who've had imaging, never had a problem. Now they are called back. Well, what's different this year? Why am I doing X, Y, and Z? So break it down for midlife women, you know, like when should they start screening? What should they start screening with? And we'll go from there.
So let me just take you back a moment just to explain what a breast radiologist is. So in order to become a breast radiologist, it means I had to go to med school for 4 years, and I'm an MD. I went to a 5-year residency for intern year, and then 4 years of radiology residency. And then I chose to do an extra year specializing in breast imaging. And that means that I'm educated on all types, all in breast imaging I'm educated on. Mammograms, ultrasounds, MRIs. I'm also the doctor that would do a biopsy if you needed a biopsy. And in many cases, I am giving the news that someone has breast cancer. So I take my role very seriously. And I think it's so important that, you know, women put a face behind who's reading their breast imaging, because I think that's important. And you want to make sure that your breast imaging is read by a board certified breast radiologist, ideally. But to be a breast radiologist, you also, in order to maintain that certification, you need to read a certain amount of mammograms per year, 960 over a 2-year period. And there's other things that we have to do to upkeep our credentials. So not all radiologists can be breast radiologists, and not all people that are reading your breast imaging are going to be breast radiologists. And in some cases, especially once you start going to thermograms and QT imaging and more alternative types of imaging, you're not even getting, in many cases, you're not getting a radiologist reading your images. So that's important. So, you know, for the general public, I would say that annual screening mammography beginning at age 40 saves the most lives, period. Okay. So there were a few important things I said there, which is average risk women. So it implies that people understand their breast cancer risk factors and many people don't. So that's an important thing that we need to talk about. And then also, the recommendation of 40 every year is a little diluted right now because there are other recommendations that exist that I don't agree with. There are recommendations from, the U.S. Preventive Task Force to say, originally they said 50 every 2 years, which was ludicrous. Right. And then they lowered it down to 45, but they still kept it every 2 years. And the reason they are recommending every 2 years is because they said that there is a higher risk of false positives, meaning you're more likely to get called back because, young women have dense breast tissue and that makes it harder to see. I'm saying a lot of words that we're going to talk about. Right. But I think that the notion that some guidelines can reflect, right, they're basing these recommendations on anxiety, not over the most life-saving information. And I think that is a very paternalistic way to do things. Right? Like, I think that women deserve to know the most life-saving recommendations and they could decide if they want to come every year or two. We don't do that for prostate cancer screening. We don't, so I think that there has to be, for some reason, breast cancer, breast imaging, breasts in general are very paternalized, they're sexualized, they are, a lot of, so I that's what bothers me. So I think that, to be clear, annual screening saves the most lives. You're less likely to be called back if you're coming every year because we have more to compare it to. And you're also less likely to be diagnosed with more, with cancer advanced. At a late stage, advanced stage cancers, because we learned the hard way during the COVID pandemic what happens when people don't come every year for their mammograms. They're getting diagnosed with late stage breast cancer. And that's the goal. I always say that early detection is the breast protection. It allows us to find your breast cancer at the earliest, most treatable stages so that you could potentially avoid more aggressive treatments like chemotherapy, lymph node dissection, and also just benefit from better survival and quality of life after breast cancer. So annual screening mammography.
Annual screening starting at 40 every year. I love that.
For average risk.
For average risk. But then you and I both know there's so much more. And then when they come in, they fill out the questionnaire. You do the risk assessment. And if they're over 20%, then the breast MRI and, on and on. And I personally feel, confident in doing a baseline mammogram at the age of 35 on my patients.
Ooh, I love that. I love that. I mean, I think that makes sense, but that's offline. But
offline, exactly. And again, I'm like you. I speak to my patients and I give them the options. It's shared decision making, and I give them and say, "This is what it is. These are the recommendations. These are my recommendations. We can meet somewhere in the middle." And I can assure you, most of my patients are like, "I'm going to do whatever I can do to avoid a problem or diagnosis, or if anything, catch it super early. Hence not having all the repercussions down the road."
And I think that that is an old school way. I used to see more people doing a baseline at 35, and the idea, 40 is an arbitrary number, right? There are lots of women, about 13,000 per year, that are going to be diagnosed with breast cancer under the age of 40. And it's hard to find those women right now. That's the problem. You have to image a lot of 35-year-olds. You're hoping you get lucky that one of the 35-year-olds that you tell to go get a mammogram goes and gets a mammogram and they find it in that mammogram. I think we're seeing more and more younger people getting diagnosed with breast cancer. So I think that I'm with you. I do think that we have to have this discussion earlier than 40. Maybe you need to start breast cancer screening earlier. Actually, one of the important recommendations that I like to talk about is that the Society of Breast Imaging recommends that all women, especially Ashkenazi Jewish and Black women, have a breast cancer risk assessment before age 30, ideally at age 25. So we can identify high-risk individuals that would benefit from earlier or supplemental screening. Yeah.
Wow.
If you go see your OBGYN in your 20s, and you might need to schedule a separate appointment for this to say, I want to run my breast cancer risk factors. And it's an easy calculator. You can even do it online for free. The Tyrer-Cuzick model.
Tyrer-Cuzick, yep.
So if you plug in that information and you see that you're over 20%, or even if you're over 15%, I would say that is a red flag that you need to go talk to someone, maybe a breast specialist, who can then, do the evaluation for, with really thoroughly. And if you are high risk for breast cancer, greater than 20% lifetime risk of breast cancer, we start breast cancer screening as early as age 25 with an MRI. And then we add on an annual mammogram beginning at age 30, and then we're alternating every 6 months.
Every 6 months,
So there are plenty of women that need to start before age 40. And I think that the scales, the calculators miss a lot of people, young people that are getting diagnosed with breast cancer, unfortunately. And that's where I think, the monthly breast exam and knowing your breast really comes into play here.
I hear that all the time. Patients are like, I'm scared to check my breast. I don't even know what I'm feeling for. And my reply to that is, yes, but you will know your own breast architecture. And hence, if something changes, you'll be the first one to notice it. And then you bring it to me and we will follow up with that. So they're afraid, but then they understand the reasoning behind it. It kind of, minimizes their fear a little bit so that they can do it.
I think there's also the fear of like, what if I find something? What if I do find this lump? And there, I have plenty of women who come into me, delayed because they're just too scared to hear what it is. But my advice would be like, the sooner you come in, the better. Hopefully it's just a cyst, and we could tell that easily with an ultrasound in many cases. But not ignorance is not bliss, especially when it comes to breast cancer.
No, that's especially with all the new treatment options and things that can be done at an earlier stage.
Exactly.
Talk to us about breast density.
Yeah.
Why? What's the difference? What happens to the breast tissue as we get older? From puberty all the way up to peri and postmenopause.
Yeah. So far we've only talked about mammograms, and mammograms are an essential part of breast imaging. We could talk about why, but they detect microcalcifications that other imaging modalities can't, like ultrasound and MRI. But I will say that ultrasound and MRI are great supplements for a mammogram, meaning in addition to your mammogram, you might want to consider adding an ultrasound or an MRI to your mammogram, especially if you have dense breast tissue. And so dense breast tissue is common. It's normal. About 50% of women have dense breast tissue. And what I mean by that is that when your breasts are composed of fat and fibroglandular tissue, or the dense breast tissue, and the more dense breast tissue you have, the whiter it appears on a mammogram, okay? Because dense breast tissue is white. The thing is, breast cancers are also white. So dense breast tissue is important because of two reasons. One, it obscures breast cancers because, like I said, they're both white. And think of it like finding a snowflake in a snowstorm. And also, we know now that dense breast tissue is the hormonally active part of the breast tissue where most of the breast cancers are forming. So by having more dense breast tissue, it also increases your risk of developing breast cancer because you have just more active breast tissue that might develop a breast cancer. So it's really like a double-edged sword. It makes it harder to see small breast cancers on a mammogram, and it increases your risk. So because of that, if you do have dense breast tissue, and you would only really know your breast density truly by getting a mammogram, or by getting some type of breast imaging where it can tell you the ratio of fibroglandular tissue to fat. So if it's over 50%, if it's more dense breast tissue than not, then you're considered dense. And you would, in your mammogram report under breast composition, it would say either heterogeneously or extremely dense. If you see that, then you have dense breast tissue, and then you might want to talk about adding an ultrasound or MRI in addition to your mammogram, depending on your risk factors.
So then I like that, there's all these different modalities. And the more the reports that I'm seeing over 25 years, and they keep evolving and changing. And now they're actually writing in there the density itself and the severity of the density. They're quantifying it now.
Right. And now, it's legally, you have to get a letter from your mammogram saying if your breasts are dense or not dense, because before it was just kind of buried in your radiology report, and no one is really reading their radiology reports. And because of advocacy and education and awareness, now that we know that dense breast tissue not only makes it harder, but it also increases your risk. Women are now being notified if they have dense breast tissue. So I think that's really important. It's really a testament to the advocacy that people have done to kind of make this known and people aware about it.
Mm-hmm. There was a recent article that I saw about finding certain things on a mammogram, I believe it was, that showed some kind of calcification that really actually turned out to be more for cardiovascular. So they picked up that. Can you talk about that? Was so exciting and interesting. I was like, look at this.
Yeah. So one of the so we see lots of calcifications in the breast, and one of the calcifications we see are breast arterial calcifications, or BAC, and we know, like, it's common to see it in older people, but every so often I'll have a young person that comes in with like heavy breast arterial calcifications. I remember I one time put in my report, I was like, atherosclerosis out of proportion to the patient's age, like correlate with, cardiovascular risk factors, because we are seeing that is an important factor that signifies whether there's really significant atherosclerosis elsewhere in the body.
Right. Yeah. I mean, imagine, like, we're getting so much better and there's so much more technology where we are picking up other disorders at the same time as, looking for, you're looking for breast and you're finding cardiovascular. So I think, and we know women's health, cardiovascular disease is at the top of the list of what could happen down the road. So it's great to have these modalities.
Yeah, and the article showed that it was a strong, readily available marker for future cardiovascular disease in women, predicting heart attacks, strokes, heart failure, and death. And we know that people are more likely to die from heart disease rather than their breast cancer. Right. So I think it's a really important thing, and another reason why you should be getting a mammogram.
Okay, I want to jump to the book. I want to talk all about Everyone Has Boobies. I want to know why, like, what drew you to write this amazing book? And, I see you're not wrong. Like, there's so much taboo over women's health, all aspects of it.
Yeah.
And the breast being sexualized is a whole nother component. So talk to us about this.
It's so funny. Like, when I was younger, I used to love writing silly poems, and I have a whole book of silly poems that my sister got published. Like, she got binded because she loved it so much. And in the book, it says, maybe I'll be a doctor. Maybe I'll write a children's book. So I think that is important to know in the back of little Robyn. That's what she loved to do. And so as I got older and I went to med school, I became a breast radiologist, and I turned to social media because I miss writing. Like, that was ultimately what drew me there, because I had 3 kids, I was burnt out, and I was like, I need a way to express myself. So I found my voice through social media. And once I kind of unlocked the floodgates with the Boobie Docs and social media, I was like, I want to write a book. And I actually spent months and months writing a book called The Girlfriend's Guide to Breast Cancer, which was going to be a guidebook for women who are newly diagnosed. And I think it would have been a great book. But there's a lot of books out there like that. And there are some really wonderful ones. And I also knew myself where I was, biting off something like that is a big undertaking that I don't know if I was mentally ready for. I was already stretched thin as it was. And I would go on walks and I would come up with silly stories about boobs. Like, I would, and I was like, wait, there's not a book out there like this. Like, there's no children's book about breasts, which is number one, should tell you there's a problem. Like, we have, so, and number 2, like, I see every day how women are made to feel about their breasts from a young age, right? Like, even when you have kids, like, we whisper about the breasts, we tell you don't show anybody, but also, like, we don't ever talk about, like, it's okay to show some people as you get older, So I think we're made to feel some sort of way about our breasts, and that we carry that throughout our lives as we get older. And that shame that we carry, they're too big, they're too small. Like, when you're developing, you're slutty if you have big boobs, I think that is just something we inherently take as fact, right? That this is how we have to feel about them. And we carry that shame throughout our lives. And I think that shame, we're embarrassed to talk about our breasts. It might, in some cases, it delays doctor's appointments because they're embarrassed or ashamed. They're scared to even feel their breasts because maybe they were taught that's like wrong. So I think that has to change. And I saw the need, and I really wrote the book like on walks, like several walks. It was just kind of coming to me. So that felt authentic to me. I have 3 young kids. I felt like this was something that there was a need for. And I mean, who better to fill this need? I mean, the book is really fun. I want to show you some of the illustrations too.
Show me.
It was such a long process. It was like a 2-year process in the end. But but the illustrations are beautiful. I found an illustrator.
Did you do those,
No,
Robyn?
God. No, I found an amazing illustrator from Pakistan who, and it's funny because again, I hired someone to help me find her, and she interviewed, 9 different illustrators. All of them say no. The 10th one says yes. And she was perfect.
Wow.
So the premise is like last week in class, I'm going to read you like 3 pages. Okay.
Sure. Tell me.
Last week in class, our teacher said, "We have a special guest." The door swung wide, and to our surprise, who walked in abreast. The class began to chuckle, followed by blank stares. "Hey kids, I'm just a boobie. There's no need to be scared." Wait, this is wrong. "Everyone has boobies. It's pretty plain to see. Everyone has boobies just like you and me." "Hey, you can't say those words, the ones that start with B. Breasts and boobies aren't bad words. It's just anatomy." So, and then
I love that. Oh my God, that is so perfect.
Thank you.
It's kind of like a Dr. Seuss take on it with the rhyme but you're making it fun and educational.
Exactly. But it also brings up really more important topics such as, but boobies can get boo-boos and have a scar or 2. My mommy's boobies have a scar. My daddy has one too. But if boobies get a boo-boo, there are things that doctors can do. They can find it, they can shrink it, they can fry it, they can freeze it, they can cut it, they can cure it, and make that boobie boo-boo go bye, bye, bye.
Oh,
that's me, by the way.
I love that. I know. I love your whole,
my kids are in the book.
The whole thing, the kids. Oh,
I know. So
it's special.
It's really special.
That's
it's something
so
I'm pretty
special.
proud of. So,
as you should be.
Yeah.
This is you though, Robyn. This is you. Yes.
My favorite part is she lives in southern New Jersey with her husband and 3 young children. She has 2 breasts.
Aww.
It's an important piece of information.
Cute.
So
that's how old are your kids, Robyn, by the way?
They are 6, 8, and 11.
How do they feel about the book?
It's so funny. My 5th grader is a little embarrassed. She's like, "You can't read it in school," but she thinks they're all so proud, and like their friends think it's really cool. So right. I just think it hasn't been done before. It's a little uncomfortable, but I'm trying to change the way we all feel about it. The kids had the funniest reaction when I read the book. Like by the end of it, they're all chanting boobies and like they are just celebrating, and it's really just fun. So they're proud, and they think it's really cool that they're cartoon characters.
That's super cute, and it's again, you're setting a precedence here, and that they're understanding. Hey, it's okay to speak about things in a certain way because we need to know this information. Like you said, listen, some adults are getting some pointers out of all of this book.
Exactly.
It's
so funny. Like my friend was texting me. She's like, "My kid loved it," but she's like, "I think my husband loved it even more. Like he just thought it was so well written and just, it brings up a taboo topic in a very inviting, fun, age appropriate, accessible way." So.
Yes. Bravo to you
Thank
for, being creative and coming up with this, knowing there's something you need to do. When you have that gut feeling, you know it. And no matter what, you can't push it down. So you have to kind of hone it in and figure out the best way that represents you and what you're trying to achieve.
Yeah. This book felt very authentic to me, and it really honored my little Robyn, and it's just something I'm really proud of. And I honestly think of it as a series of books. That's what
I was thinking. What's next with this? Because there's more you can do with this for sure, right?
Well, Booberty's next.
Oh my gosh. I love that.
So
wow.
I've already started writing it, and it's halfway done. My creative juices are flowing.
Yeah. I can tell. I'm like, she's on a roll.
Just need more time.
Just keep going on your walks because it looks like that's where it's all happening.
It totally is. Yeah.
Oh, that is so wonderful.
Yeah, thank you.
Okay. Now I'm going to go back to something serious.
Yeah.
You mentioned it, and now I want to talk about it again. These other imaging modalities. If a woman tells you, I want to do thermography because I don't like my breast being squished with the mammogram machine, it's uncomfortable. Or another one we've heard about, her IQ, that
QT imaging. Don't get me started.
QT imaging, where it looks amazing and it's so comfortable. And then I look into it and I'm like, wait, what?
Yeah.
What's that? What? Talk to me about it.
So unfortunately, because breast cancer is so common and, women are getting diagnosed more frequently, people see that as a opportunity to make money. Okay. So you'll have alternative kind of imaging, you'll see so much misinformation online, starting from imaging and then going into how to prevent breast cancer, how to treat it naturally, like every level of breast cancer. Unfortunately, there's misinformation out there. So starting with the breast imaging, there are people out there that are spreading lies or swaying the truth. Okay. So saying that mammograms cause cancer because mammograms have radiation and radiation is bad, then mammograms cause cancer. So let's back up here a little bit. So mammograms are an X-ray of the breast. We use X-rays in medical imaging all over the body, and they play a really important role. There are some things that X-rays can do that other imaging modalities cannot, such as when you break a bone, because it is an X-ray, it could look at bone and calcifications well. But ultrasound and MRI are great imaging modalities for other things, but they can't detect bone breaks. They can't detect, microcalcifications. So mammograms have a very small amount of radiation. It's comparable to about 7 weeks of background radiation. We're exposed to radiation all the time in our daily living, from radon and our home and from, the space. So it's equivalent to about 7 weeks of background radiation. It's a very small, it's really 3 millisieverts of U, but less than 3 millisieverts of U, which means nothing to you, but that's what it's equivalent to.
Right.
Or flying cross country. But that small amount of radiation allows us to detect microcalcifications and other early findings such as distortion, which can be the earliest signs of breast cancer. So, ultrasound and MRI aren't good at finding those. They can't detect those microcalcifications, which are beyond the resolution. So that's why I think that mammograms, and they also allow us to screen a large population of people in a cost-effective way. So, should everyone be getting a breast MRI? Probably, but is it cost-effective and efficient and reasonable? Like, again, MRIs are expensive. They take depending on it, if you get an abbreviated MRI now, they can be as short as 15 minutes, but they can go up to 45 minutes. You go in a magnet, it requires gadolinium dye, which is a heavy metal. So there's issues there. So when you're talking about screening a general population, mammography plays a role. Okay, so now there are people that are going to try to scare you away from getting a mammogram and trying to sell you something alternatively, such as a thermogram, or now we're seeing QT imaging. So thermogram is looking at inflammation in the body. It's a snapshot of the entire body. And it is so bad at detecting breast cancer that there is an FDA warning that, they said it's not approved to replace mammograms. And the FDA has come out and said that anyone who tries to sell it as instead of a mammogram, they're going to come after them because it's not even comparable. It's a different type of imaging test. It doesn't look at microcalcifications. It's looking at a global picture of the whole body. It's a snapshot in time. And I've seen so many women who will come to me for both sides. They have an abnormal thermogram, and they're coming to, when you have something abnormal with a thermogram or QT imaging, they're going to recommend a mammogram. Okay. Mammogram, yeah. Right. So they come in because they had an abnormal thermogram. They get a mammogram. There's nothing there. We're kind of stuck, at what to do. And the opposite is true. We see plenty of women getting thermograms for years. They don't understand why they're diagnosed with this late stage cancer because they've been having negative thermograms. So It's not a test for breast cancer screening. If you really want to look at the generalized inflammation in your body, sure, consider a thermogram, but it's not going to detect your breast cancer early. So that was number one. And I think that the same people that are now selling QT imaging were previously trying to sell thermograms until it kind of got debunked enough that they decided now they have to do something else. So now, and when I say doctors, we know we're talking about this one doctor that's
one doctor in particular,
monster.
correct.
But so she now is selling QT imaging, which is an ultrasound. It's a 3D ultrasound. And it is not interpreted by breast radiologists. I know this because I have the imaging reports. It's $900 out of pocket or $600 or whatever it is. And again, that's not approved to replace a mammogram. It's really the way it's being marketed is different from what its utility is. If you really wanted to know your breast composition in your 20s or 30s, then it might be a good test for you if that's like why you want to get it. But it's not going to detect your breast cancer early. It says it all over the imaging report that this is not, this is not going to detect microcalcifications, and it's not going, in many cases, it's not going to detect DCIS, which is early stage breast cancer.
Early stage.
Again, that we could argue about that as well, because they're going to tell you that's not cancer.
Right.
So it's kind of like this confusion. It's like a bait and switch type of thing where they're trying to scare you away from getting the screening test that all your doctors are recommending and all scientific societies are recommending. They're saying that their imaging test is 40 times the resolution of MRI. Like, I don't know where they're getting these numbers from. And if it was so good, breast radiologists would be involved.
Correct.
Okay. Right. We talked about how I'm up to date on all types of imaging modalities. And there are things like, we know the mammography is not perfect, but it is improving. I personally love contrast mammography.
I was going to say the contrast enhanced.
Yeah.
Yes,
We've been using it since 2011 in my institution. And it's basically like a mammogram and an MRI had a baby. So it has all the benefit of the contrast, but it's not a gadolinium contrast. This is iodine. And it also is able to detect the calcifications of a mammogram. So I think that is really the wave of the future. Breast CT is something that's promising. I'm not entirely on board yet, but there's no role right now for QT imaging. There's no role for a thermogram. If there was, I would be on board because I am trained to read every type of breast imaging modality that's approved.
And you're an advocate.
Yeah.
You're an advocate for women and you want them to have the best, imaging study. So if that's the case, let's get some data together and let's make it the gold standard.
Like my job as a breast radiologist is to find your breast cancer early.
Right.
If I was doing that,
whatever modality,
whatever that is, I'm not paid by the mammogram company to say that you need a mammogram. That's number one.
Right.
I think that's that is also so then there's this conflict of interest. Like the same person that's pushing you to get this QT imaging is often reading the exam. And recommending the follow-up. Like they could say whatever they want. There's no guidelines that they're following. There's no data that they're following. It's really scary. And I've seen the reports. Like the reports are gibberish. It's talking. It's like speaking in a foreign language that nobody knows or understands. And you're paying $1,000 for this report that is nonsense, honestly. And like I said, if there's anything abnormal, they're going to recommend a mammogram, the same one they were just trying to scare you away from getting.
Right. And, it's easy to, I think, feed on women's fears at this point. And with access to social media, it's quite easy for women to kind of get confused a little bit and want to go that way.
It's fear mongering and it's also like clickbait, like those videos that are like, your mammogram's causing you cancer. And you're like, what? Like, I just about to go get one today. And now I'm like, I'm all ears. And that's the problem is that stuff is getting the views and the shares and it's going viral for all the wrong reasons. And I think that's something that buyer beware. Like whenever you see on the internet, I think you really need to ask yourself, what is their credentials? Number one. And what are they selling? Do they have an ulterior motive? Like, are they making money per QT imaging scan, or are they, they're reading whatever scan I'm getting because that's the most, effective way to screen for breast cancer.
And, in terms of follow-ups and things like that for patients, right? how do you feel about, let's talk about like, a high risk individual with a previvor, we're talking. Let's say, someone who has a BRCA premutation or any other kind of genetic premutation for breast cancer, and they want to know, what is my follow-up? How often do I need to be seen? What imaging do I need to do? What is the protocol, basically?
Yeah. So if you are BRCA or, high risk greater than 20%, I would start with an MRI beginning at age 25. But again, if you find out you're BRCA at 35, start then. It's not too late.
Right.
It's never too late to find that information. But what you do with that information is going to change, right? So definitely an annual MRI. We start doing an annual mammogram beginning at age 30. I personally like going every 6 months and alternating. So you're never going more than 6 months without breast imaging, because we just know that BRCA patients are more likely to develop more aggressive breast cancers that can pop up in between, 6 to 8 months. So, and we're seeing that with younger people. Like I don't do this. Like I have dense breast tissue. I'm average to intermediate risk. I do my mammogram and my ultrasound at the same time for convenience. But in an ideal world, I think it would probably be good to stagger them too.
Stagger. Yeah. More, you're looking at the breast tissue more frequently. That way it gives you a little bit more information.
It kind of goes both ways, because it also, like, sometimes we'll see something on a mammogram, but we know we're getting the survey ultrasound. So it's good that we can just go see what that thing is. So correct. I don't know. I don't know what the right answer is there.
And I think that's part of the reason to have women stay with the same center doing the imaging. That way they have point of reference to go back to if they see something different.
Exactly.
Right?
It is so important to have comparisons. Like what your breast tissue looks like is your breast tissue, and it will look somewhat similar over years. It should. We mentioned breast density, or breasts tend to get a little bit less dense over time, but not always. So I think it's important. It is kind of harmful when patients hop from one to another, especially if they're not bringing their whole arsenal of breast imaging. It's really important. With them. Yeah. I also want to talk about, you mentioned something about, getting called back and how scary that is. And so I wanted to talk a little bit about that. About 10% of women will get called back from a screening mammogram. It means you get a BI-RAD 0. When we talk about breast imaging, we use something called the Breast Imaging Reporting and Data System, or BI-RADS, and you get different BI-RAD codes regarding what the imaging findings are and the recommendations. So if you get called back from a mammogram, it's too early to panic. I would say read the imaging report and see exactly what the radiologist is saying about what it is. Is it there's a new irregular mass with calcifications, or is it a focal asymmetry? So I think you can kind of gauge the suspicion based on the words that the radiologist is saying in the report. So if you get called back, look at the imaging findings, maybe even ask your doctor about, what does this mean? There are some things that are more suspicious than others. So when you get called back from a mammogram, like we said, out of 100 women, 10 of them will be called back from a mammogram. Okay. Of those 10 women that get called back from a mammogram, 6 of those women will be told that everything is normal. It was just overlapping tissue. It was just a cyst. 2 of those women will be told it's probably benign. And we're saying, the radiologist is saying that you have a less than 2% chance of this being cancer. And we basically follow you closely. We follow you at 6-month intervals for about 2 years until we prove that it's not changing. So that is a BI-RADS 3, probably benign. And then of those, 10 women, 6 of them told it's benign, 2 of them told it's probably benign, 2 of them will be told they need a biopsy. Okay. Of the biopsies we do, 80% of them are benign. When we're talking about BI-RADS 4 means it's suspicious. Now, if you are told that it's highly suspicious by a radiologist, unfortunately, the radiologist is basically saying, this is breast cancer. It's not. If we biopsy it and it's benign, I'm going to recommend that it comes out because it looks like breast cancer. And that's, we're starting to gather the team. So you're mentally prepared that that's what they're saying, but a biopsy is still important because it tells us, one, is it in fact breast cancer, or is it some kind of mimic with, like, granulomatous mastitis can look like breast cancer? It will tell us, number 2, what type of breast cancer it is, because breast cancer is really hundreds of diseases depending on the receptors, the grade, the size. So that is all really important as well. So It will tell us, is it breast cancer, but also what type, what subtypes, what hormone receptors does it have? All that is very important. Breast cancer treatment is a very individualized approach with multidisciplinary team. So it includes surgery, oncology, radiation oncology, pathology, physical therapy, all those things are coming into play, plastic surgery. So
all of it. Yeah, it's a whole team effort at that point.
But again, once there's a diagnosis, then we're going to help you get the best treatment plan for you. We're going to get you the best experts on your team. And I think a lot of women feel better once they have their team and a plan in place. I think it's that unknown that is really concerning for patients.
Scary for them. Yeah, I think so. So if a woman feels, like these screening guidelines are kind of confusing for them, what's the best way for them to decide, to approach decision making?
Well, follow the Boobie Docs, just kidding. But also, like we said, annual screening mammography beginning at age 40 saves the most lives. I think you have to, at the end of the day, find where you are in the spectrum of, if you were diagnosed with breast cancer, would you want to know at the earliest stage, with the disclaimer that we might find some things additionally that are not breast cancer that might need a biopsy, but then once it's biopsy, we can prove it's not, cancer. Are you like, I want to find my breast cancer at the earliest stage? There's that one camp. And then there's the other camp that's like, I don't want to know. Like, I get worried every time I go for a mammogram. I wouldn't want extra biopsies because I'm just scared of the whole thing. That's another camp. So I think you have to understand where you fit on that spectrum. And have a conversation with your doctor. Because if you're on this camp where you want to do everything, you want to find it at the earliest stage, get a mammogram. If you have dense breast tissue, add an ultrasound or an MRI. And I think both camps really need to also get familiar and do a monthly self-breast exam and get to know how their breasts normally look and feel, especially if you're on this camp where it's like you're not going every year. So I think that somewhere in the middle is where we all need to be.
Okay. And one final question for you, Robyn. What's the one message you hope listeners walk away with about breast health and screening?
Early detection is the breast protection. When we could find your breast cancer early, it can treat it in a less aggressive way. You're going to survive the breast cancer. You're going to have a great quality of life after breast cancer. Breast cancer, when it's caught, when it's localized to the breast, you have a greater than 99% survival rate. So breast cancer potentially has the ability to not kill you. Okay. But it's the things that we do when we're diagnosed with breast cancer. And then we're trying, if we get distracted and fall down these rabbit holes of alternate medicine or alternate screening and imaging, then that's where the bad things happen. That's when we should not be dying from breast cancer, especially when it's localized these days, because of the advances in treatment, in screening, and prevention, protection, all those things. So it's really heartbreaking when I see young people dying from breast cancer that could have been avoided if they got the screening that was recommended and they got the treatment that was recommended. Yeah, that's my take-home point.
Thank you so much for being here. That is so much amazing information that I know that my audience is going to love. And where can they find you for more information?
Yes, so you could follow me at the Boobie Docs, Boobie Docs. You can also check out the boobiedocs.com where I have links to all my book, some resources, some media appearances I've done. You could ask questions. I also have a podcast, The Girlfriend's Guide to Breast Cancer, for those who are navigating a breast cancer diagnosis or supporting a loved one. And also check out my book, Everyone Has Boobies, available now at major online retailers.
Amazing. Thank you so much again. Thank you for being here.
Thank you so much. This is such a great conversation.